Hi, my name is Amrinder Sidhu, and I will be presenting the drug gene pair of tamoxifen and CYP2D6. During the course of this presentation, we will talk about the tamoxifen drug, CYP2D6 gene, its variations, and then finally the current state of pharmacogenomics research for tamoxifen and CYP2D6 genotyping. Tamoxifen is a small molecule drug that is used for treatment of metastatic breast cancer in women and men. It acts as estrogen inhibitor in mammary tissue and estrogen stimulant in endometrial and some other tissues. It's also used for adjuvant therapy for breast cancer after patients have undergone surgery, radiation, and/or chemotherapy. It reduces the risk of invasive breast cancer for women who have had ductal carcinoma in situ, and also used for prophylactic therapy for women who are at high risk of breast cancer. Common side effects of the drug include hot flashes, which occur in 80% of the recipients, and vaginal discharge. There's some less common but more serious, some even fatal effects of the drug, which are also included on the drug label. These include endometrial cancers, thromboembolic events like DVT and pulmonary embolism, cataracts, and enhanced risk of a stroke. It has been demonstrated that in some animal studies, high doses of tamoxifen produce convulsions and respiratory difficulties. Tamoxifen is a prodrug, and its active metabolites are responsible for the success of therapy. There are two major pathways for the metabolism that account for about 99% of tamoxifen metabolism, and CYP2D6 plays a key role in each one of them. Most important metabolite is endoxifen, which results from hydroxylation of N-desmethyl tamoxifen, and that reaction is primarily catalyzed by CYP2D6. CYP2D6 is believed to be involved in the metabolism of 25% of the drugs that are in common use. There are over 90 known allele variants, and over time a system has emerged which helps in categorizing patients based upon their CYP2D6 metabolizing status, resulting from the variants that they have. These categories are ultra-rapid metabolizers, extensive metabolizers, intermediate metabolizers, and poor metabolizers. There's a widespread interethnic differences across various populations. Poor metabolizers are mainly found in European populations. Ultra-metabolizers are found in North African and Oceania populations, and intermediate metabolizers mostly in Asian populations. Again, the functional impact of polymorphism depends on recipient's metabolizing status. If the drug is pharmacologically active, ultra-metabolizers typically have low efficacy, and if the drug metabolites are active, poor metabolizers may not get much relief from using the drug. So the logical argument would be that since CYP2D6 plays a key role in tamoxifen metabolism, associated CYP2D6 variants should influence clinical outcomes. This has spawned a whole lot of pharmacogenomics research, which has resulted in some contradictive evidence in recent times. And these differences stem around a few factors, which include menopausal status of patients included in the study. It is believed that in postmenopausal women, tamoxifen and N-desmethyl tamoxifen occupy 99.9% of available estrogen receptors, and as a result, variations in endoxifen concentration play a little role in blocking estrogen signaling. CYP2D6 is very difficult to genotype comprehensively, and as a result, categorization of CYP2D6 metabolizer status is not very accurate. SSRI class of drugs that are used to treat hot flashes, main side effect of tamoxifen, inhibit CYP2D6 activity. So some of the in vivo concentrations of endoxifen may not be what are expected if patients are also taking these drugs. Finally, inclusion of patients who are on combination therapy, that is, patients who are receiving additional systemic therapy in addition to tamoxifen, may have contributed to negative results in associating CYP2D6 genotyping and tamoxifen outcomes. The current state of pharmacogenomics research doesn't warrant a broad clinical use for PGX labeling. However, tamoxifen continues to be used broadly for treatment of metastatic breast cancer, and future studies need to account for this recent evidence that has emerged. And these factors mainly include conducting studies relating in vivo concentrations of tamoxifen metabolites to clinical outcomes, more comprehensive CYP2D6 genotyping, and defining better study cohorts that account for confounding factors like menopausal status and tamoxifen combination therapy. This concludes my presentation. I hope you like it. Thank you.